Okay, good morning, and thank you everybody for coming, also to the people online. I will really use just a couple of minutes to welcome you. Basically, I'm here because we are using our facilities for this conference. I'm a sociologist. My name is Andrea Miconi. I work for Ulm University. So just a few words to thank basically the network of the Horizon Europe EuCARE project for visiting us and for presenting results, findings, and sharing ideas in a location which is quite unconventional. We don't have any expertise in biomedical studies. We are mostly a communication universities. Still, I will take this as a positive sign in the hope that in the future there will be a more systematic and fruitful debate. I will rephrase, in the hope that there will be any debate, because in the last 4 years, debate was not allowed. And as a social scientist, mostly working on critical theory, this is hardly acceptable for me. And I would add that this is even less acceptable in the case of pandemics, because what pandemics do is affecting all levels of society, which means a pandemic is by definition a multidimensional problem. Multidimensional problems call for multidisciplinary solutions. So I hope that in the next years we will have a better dialogue. I hope that there will be discussion around public policies and the way this kind of health issues can be handled. But still, I know that this is the work you have been doing on the specific case of schools. So thank you again for being here, and just to welcome you again. And we have all day for the discussion.
Thank you, Andrea. Thank you very much, actually, for hosting us in this wonderful place in the very center of Rome. Fantastic. And I would invite Patricia Urban-Lopez, who is our officer from the European Commission, to give her salutation. Hello, Patricia.
Hello, good morning, everyone. I hope you can hear me well. If not, please let me know.
Yes, perfect.
Yes, we can see.
It's my pleasure to be here today, and I apologize for not being in person with you. So thank you so much for the invitation and for the organization of what is anticipated a super interesting conference to really see the power of science for pandemic and to understand what we can learn from the past to really move forward so we can be better prepared in the future. Because unfortunately, the reality is that pandemics seem to be more likely to occur than before because of many aspects, such as the climate change, the increased land use by human population, and also the increased animal to human contact, among others. And I'm not a social science person, but I also wanted to say that the impact of pandemic affects all levels of our society. So that it impacts the human health, the healthcare systems, but it has very important impacts at social level, economic level, and political level. And that the role of research in this is central, and it cannot be underestimated. And I'm here as a policy officer from the European Commission, from the Department of Research and Innovation. So of course, this is my area, but I truly believe that the role of research is critical on this, and we could show this during COVID, because during COVID, the EU research was instrumental, and EuCARE was part of this, your project, to advance our understanding of the virus, to develop diagnostics, treatments, vaccines, and to inform the policies, public health policies. Let's not forget that the COVID-19 vaccines did not come out of the blue. They were based in year-long research investments before, more than 10 years of investment in the mRNA technologies in other areas, such as cancer, but the technology was ready to be applied when needed, rapidly, to make the vaccine for COVID happen. And one lesson that keeps coming back also for research and innovation is the importance of working together. And I think, Francesca, in the EuCARE project, you have mastered that. And you will show this over the day with the different activities that you have done and the geographical spread and the considerations that you have in the project. And also EuCARE have helped to show the important role of cohorts in responding to the pandemics by helping to understand the disease and how this affects the population, no? And I also wanted to highlight the importance of the school studies. Maybe this is something that touches me personally because I was living in Lombardy when the COVID pandemic started, and I could not believe when I received this message that my children could not attend the school the next year. I was so shocked, and then, you know, so this has also a personal dimension for me as well. But I think that the work that you have done within EuCARE and that you will be showing to help to manage the pandemic by studying the impact, not only in hospitals, but in schools, to inform policies, and importantly, another aspect, the mental health effects. Let's not forget this. For all of us, because it was a difficult situation, but for the school, for the children, you know, and how you were able to provide scientific evidence to provide the insights for safely reopening the school. Last but not least, I want to have a forward-looking ending in my intervention. As a European Commission, we are committed to continue joining efforts with the member states to show the importance of research, and in particular in preparedness and response. And European partnerships with member states are a crucial key for this. And now we are in the last steps of the preparations of the European Partnership for Pandemic Preparedness, which will bring together member states with the Commission to help us be coordinated and look together in the same direction, to learn from the lessons from the COVID-19 pandemic in order to ensure we have a research and innovation agenda that is agreed, that covers all the spectrum of research, from basic research to clinical research, implement public health measures, so we are better prepared and can respond. So this is a bit what I wanted to say. Thank you so much for the possibility to open this event today. Thank you so much for organizing it, and I'm really looking forward to learn more from the different presentations. Over.
Thank you very much, Patricia, for your kind words and for the insights also that you gave us on the future policies of the European Commission. So thanks again, Ulm, for hosting us, and thanks to the European Union for funding us and funding all this event. And thank you, everybody, for being here. So where did everything start? At least for me, where did I start? I am the coordinator of the EuResist Network, which is a European grouping making research on HIV and other infectious diseases. And during the COVID-19 pandemic, all my collaborators, the real scientists of the group, were completely overwhelmed with their hospital duties. They were virologists and infectious diseases experts. So all our projects on all viruses like HIV were stopped, and I found myself almost without job, without work. So as a mother and a scientist, I started devoting myself to the school issue. And indeed, I realized that Italy kept the schools closed much more than any other European country, much more than the average of all the world countries. And I realized that this was the evidence of the benefit of this measure was at least lacking, if not on the opposite sign. And also the damages caused by this measure were not known, but also not considered, not taken into account. And so in the end, I realized that the rights of the child, the rights of the children were overlooked blatantly, the right to education, but less obviously the rights stated by the Charter of the Rights of the Child. The third right is the one that all actions concerning the children should be in the best interest of the children. This was not obvious in general, I think, not only to me, because I had, even when there was a voice to supporting the opening of the school, one of the arguments was to let the mothers go to work, which is, of course, a very nice argument, but is not in the interest of the child. So I realized that it is hard to respect the rights of the child, even in our developed and rich democracies. This is, of course, my personal view. I know that school closure, containment measures, the level of infectivity of children were very debated issues and are still debated. And I join Andrea saying that I would like to have discussion, and I envisage debate and discussion today, which is something I really like and I hope. So I started marching in the streets to defend the rights of the child, maybe forgetting my children at home. And while I was doing this, of course, there were other people working on the school issue. And among the scientists I work with, Rolf Kaiser developed the Lolly method, which is a diagnostic method designed to work in the school and which was actually implemented in North Rhine-Westphalia during the pandemic. I mean, overall, the North Rhine-Westphalia. And Sara Gandini, who is an epidemiologist, she also worked on this and made an important study which was actually used in the end by the Italian government as a support to reopen the schools. Giuseppe Ippolito, as a highly respected scientist in the Italian Scientific Technical Committee, giving advice to the government, was fighting with the political decision makers to have the school open. So leveraging on the Euresist network curriculum in European research projects and pulling together this group of scientists, we decided to include the school topic into a larger project on COVID-19, so which was in the end funded thanks to the long view of the European Commission, which we thank again. And it was the EuCARE project. It is the EuCARE project started exactly 3 years ago. The overarching aim of the school pillar of the EuCARE project is to find scientific evidence to support the school mission. And more in particular, the objectives were to evaluate the efficacy of the Lolly method with a clinical trial, randomized clinical trial, to study the epidemiology of the virus into the school, among the populations in the school, and to evaluate the psychological impact of the containment measures and also the related learning loss. I must say that the study was very difficult. We encountered a lot of obstacles. From the ethics point of view, the minors, the school environment is particularly sensitive. And so we also had some negative answers from the ethical committees. Then, of course, the schools were coming from a very stressful period, and somehow to think again of COVID and to do some extra work in order to participate in the project was an extra stress. And the schools are not used to participate in research studies. They don't have the administrative support to do this. And this is really an aspect that I think we should work on somehow. So I want to thank very much the schools. I don't know if there is my slide, but I only have one slide thanking the schools because they did it. The schools that participated, all the people in the schools who participated in the study did it with passion. They did it on their forces without support, as I said. They did it because they understood the relevance of the scientific research. And I think they also expressed somehow the need to find ways to cope with the suffer that they had during the COVID, and the possibility also to express their voice. So thank you very much. We will have several school representatives today in the sessions and in the round table, and I really want to say this is, you are the center of all this story. So today we can proudly present the results of our study. Rolf Kaiser will illustrate the Lolly method and also how it can be further powered. Anna Bekashish will present how the Lolly method can be used also to identify the variants in advance. Gibran Oremheb will show how the Lolly method can be implemented not only in a rich European country, but also in Mexico, for instance. And Sara Gandini will present the results of the randomized trial on the efficacy of the Lolly and on the psychological impact of the containment measures and its relation with the learning loss. Francis Drobniewski will describe the vaccine hesitancy in the school population. And then we have representatives from the schools, Marta Diaz from Portugal, Chiara Stancari and Silvia Scandura from the north and south of Italy, who will tell us about their experience with COVID, with participating in EuCARE. But the school is not the only aspect of the management of pandemic. It's probably a good example of the difficulties. But there is a whole area to be analyzed of the role of science in policy implementation in emergency situations when it is decisions need to be taken rapidly and maybe with little scientific evidence, at least in the beginning. So in a very complex situation when the political decision maker has to take into account many aspects that maybe the scientific world does not know. And on the other side, the scientific world has to collect and interpret the evidence, which is not easy. It's of course a matter of debate, particularly when the evidence is coming and is scarce. And in this case, when there is a scarce evidence, the use of model is usually of help, but we have to consider that the models may be based on different situations, and so their results should be taken with even more than a pinch of salt. So I'm really honored that today we have primary level scientists, internationally known scientists, who will help us shed some light on these aspects, which are of the highest relevance. And I think they will also shed probably lights of different colors. As I said, I expect some debate, which is good for science and for all of us. John Ioannidis, with his eminently methodological approach, will guide us in revisiting some of the pandemic choices, questioning the level of evidence of the evidence. We will have then an in-depth analysis on the evidence with Tom Jefferson, who will discuss one specific but very diffused case, which is that of the masks, use of masks. Giuseppe Ippolito will analyze the relationship among science and politics, which is a crucial interface, of course, which is probably has been not enough studied per se, which probably needs more research. And again, here we'll have some more in-depth analysis, probably, on one of the crucial aspects of the relation of policy and research, where Patrizio Pezzotti will present the experience with the data collected by the Italian National Institute of Health, the ISS, and their use to guide the policies during the pandemic. Sunetra Gupta will problematize the use of mathematical models and probably somehow discuss with Vittoria Colizza, who is an expert on mathematical models and will present her experience with modeling school data and as policy advisor in France. Kevin Bardosh will focus specifically on the harms of COVID policies, providing an overview of the presently available evidence on this. And of course, the school is a good example. Andrea Miconi, our kind host, will bring the different perspective, which is really important, as he said. The analysis of the language, the words used by the medical discourse using the pandemic. And I bet that the language is, of course, also a measure, a political implementation somehow. And I bet his presentation will be in dialogue with the one by Francis on the vaccine hesitancy. In the roundtable, we will have the possibility to discuss with representatives of some involved institutions. Patricia Urban Lopez will stay with us. And Francesca Morpurgo is here from the local administration of the municipality of Rome. Patrizia Falsetti represents the INVALSI, the Italian National Institute for the Evaluation of the Educational System. And Pierluigi Lupalco, further to being one of the researchers in the EuCARE project, is also a member of the regional council in Puglia. We will have the point of view of the schools, again, including from Germany with Karin Fassbender, and from Lecce with Maria Antonietta Caus, Fabiana Gravili, and Ornella Castellano. Elisa Tomezzoli will allow us to go more in depth in the way we evaluated the psychological issues. And bringing the discourse back to the beginning, I think Thomas Fazzi will question whether the management of the pandemic has been equitable. So we started from the rights of the child, and I think he will broaden the perspective to other disparities, those among North and South, and the wealthy and the poor. So I hope it will be, there will be debate, there will be discussion. I invite everybody here and online to make questions, and I wish us all a good conference. Thank you.
Yeah, good morning, and thank you very much for coming. And it's really a great honor and a great pleasure to be here and to have these sessions with you. So I will not make many words up front. I just wanted to say that our intention was to keep the schools and daycare facilities open. That was the aim, and it was not to fish out any spreading infectious sources or whatever you call it. We wanted to keep the schools and daycare facilities open. And so I'm really happy that Karin is here with us today to support us on this issue. And in the beginning, when this pandemic came, we were all shocked and had the pictures of the Spanish flu again, when many people and also many children died, and we did not know how to protect the population and the children. And so then we sat together and developed plans to monitor and to keep the facilities open. And we want to learn from this pandemic of SARS. Currently, nobody talks about SARS anymore, although, at least in Germany, it is the most frequent infectious respiratory disease still today, and is an X-fold frequency of the second most prevalent pathogen, which is rhinovirus. So we still have SARS, and we still have a lot of other respiratory diseases around, and we want to be prepared. So one of the words is preparedness for the next pandemic. And what do we learn? How can we approach the next problem to avoid school closures and things like that? So it's now my pleasure to announce Giuseppe Ippolito, San Camillo's International University of Health and Science. So introducing Giuseppe Ippolito in Italy is what we call bringing owls to Athens. I think he's one of the best known scientists, and he's an institution in Italy. So now you're with the San Camillo's International University of Health Sciences, and you are full professor of infectious diseases at the university here in Rome. And for many years, he was the Director General for Research and Health Innovation at the Italian Ministry of Health, and for more than 20 years, the Scientific Director of the National Institute of Infectious Diseases, Lazzaro Spallanzani, in Rome, and for 12 years, Director of the WHO CC for Highly Infectious Diseases. So this is really a great honor to have you here. And this Spallanzani is the CDC from Italy, for those of us who are foreigners and do not know the Italian situation.
My previous experience suggests I have a large disclaimer that I have no conflict of interest, and what I will present, I've expressed my ideas, and I have no relation with my dreams or actual position. So just let me try to make evident the difference between scientists and the politicians during an epidemic. In my opinion, politicians are bad, the left or right party are bad. To 2020. Oh, sorry, until the end of 2022. Disease. Avanti. Non va. Okay. The problem of infectious disease is paralleled by the risk of biological, chemical, and the nuclear hazard. In the public perception, the problem of infectious disease and the nuclear war are exactly on the same level. But how to deal with a pandemic? During a pandemic is this domino effect. It's very difficult to control the situation. It's considered early detection is very useful to collect all the information for rapid response to taking appropriate action. And not all the action are appropriate if you are under pressure, under societal and the political pressure. There are some problems that are really unresolved, not appropriate evaluation of threats. The second is the problem to take a decision without data, without plans and the program. It's very, very difficult to do coordination during a pandemic. The organization of public health infrastructure is lacking everywhere in the world. Richard Orton in October 2020 wrote a wonderful editorial on science and politics on the era of the COVID, and I will use this as a body copy for the presentation. The uncertainty is really important. How to manage? No a single recipe for control the pandemic. The problem of a strict intersection between politics and health. The pressure on the public health officer by politicians that not consider science is core of the decision, and the breakdown between science and the politics that consider it is not enough. Two examples. One is the UK examples with the step 4 of the UK approach, removing immediately as soon as possible all the legal restriction. Now there is a large debate in UK. Removing the face mask. The second was the stop to the instruction to the population and information about the stay home if you have respiratory symptoms. The third is the use of a green pass, and the fourth is isolation exemption for contact of positive cases. This is a tremendous impact. If you consider UK versus Italy, and we see that the number of avoided deaths is relevant in all the country, excluding France and Sweden. During the actual debate in UK, we have two positions. Patrick Wallace was chief scientist at the time of the pandemic, and reported Boris Johnson tried to understand the graphics, but this is paralleled by similar approach in the other country, including Italy. And this Shahid Jamel, that was advisor to the Indian government, reported that most politicians, not all, are honest about not knowing enough in science. And in September 2022, Nature published this analysis on the restriction of social contacts that provided some type of positive evaluation, some time of negative evaluation. But if you consider that quite all are considered to be positive in terms of reduction of the impact, more or less, including the best results was for cancel mass gathering and appropriate information and communication to the public. We consider science must be the guide of the situation, and there is not a new problem. Just before COVID-19, the guidelines for scientific advice were largely common. A lot of books to consider that science must be really separate from the politics, and to take the decision in an uncertain situation. You have not to select the scientist and expert to guide the situation. If you guide the situation, you have these conditions that you see here to try to avoid to take the appropriate decision. Rolf Dieter was chief of the scientist for scientific advice in November 2020 at the European Commission. He was not, and what is the report? Scientists must be engaged with the general public in providing information, but this was not successful. We have a lot of false prophet everywhere in the world. If this is a key word to manage the situation, we have the experience with the Dr. Fauci. Dr. Fauci reported that political decisions were not based on scientific evidence, and no scientific evidence spread by social media generate confusion. Was not useful to create appropriate response and reduce the credibility of public, of scientists, create a position by the government that were contradictory and erratic, and the political decision makers are not able to work together respecting the role of scientists. No one have a crystal ball to see the situation, and the analysis of scientific evidence that was published a few months ago reported that in the majority of discussion on evidence was reported but mentioned in the publication, and in the generic publication was less in 1 in 4. This was the same for therapeutics, the same, and otherwise the complotism and the controversies on vaccine was increasing. It was the effect of communicating with the statistic on public trust. Well, we have the analysis performed in terms of numeric and verbal in different countries, in also to consider this as a way to increase the trust in the decision. We have probably the possibility to mathematical model, but assumptions are not enough to take appropriate decision. When Victoria published the mathematical model on influenza, my son used your model for graduation. Most of the information that now are useful were already there, but no one tried to apply it across the year. And the request for more data for politicians could be the problem to postpone decision making. This is named the delay fallacy, And this book is totally devoted to the lack of argumentation during the pandemic. It's very nice. It's a 2-year-old book. The scientists have a crucial role in the decision, and the trust in science is increasing during the pandemic. Science is increasing, and the science is in the country. Doctor and the nurses increased, but journalists was stable, and the national government don't increase during the pandemic in a similar way. But recently, just a few days ago, in mid-November, another analysis on the trusted scientists has been performed in the States, and the confidence after the pandemic decreased, and now is at a level that is lower than during of the pandemic. We have the request to be neutral in science. This is Encyclopedia in Science, a special chapter on the neutrality on science and the relation between science, technology, and ethics is named the neutrality. But this neutrality is not easy to manage, and considering all the aspects of science and technology, and some assertion of neutralities are to avoid the responsibility and the consequence. This is very real. I experienced personally. This is one of examples. The declaration of future President Trump in May, with the idea to change the perspective, removing the problem of media, and making the American prone to the disaster. And just after re-election, this poll on X to restart the trial against Tony Fauci and Bill Gates. But Americans, this has been published just a few days ago, 1 week after the election of Trump, report that more than half of responders in this sample population in the States report that scientists must have active role in France, in the United States. And as a response, the presidents of National Academy of Science reported that science is not red or blue. So if science is not red or blue, the community of science need to work, since the perception of a political motivation, of the perception of that scientists are politically motivated, has negative impact on the population. And not all the scientists are good communicators, in this assume that most of the scientists are intelligent and clever. The limitation of use of science, and I will finish, science alone is not able to decide the policy action. The responsibility must be of politicians. The decision without perspective of future impact is not really useful, and this is the reason why politicians must take the responsibility. Policy matter cannot afford ignoring the role of expert, and but they cannot say the responsibility by the authority of scientists, and having clear role of this limitation require humility. Humility is very difficult, is not common, but scientists and policymakers recognizing that they work in two different domains. Thank you.
Giuseppe Ippolito, thank you for being told by such an important person that we have to learn humility, and that we are scientists, and that we have to think of ourselves, that we can make mistakes and can also discuss these mistakes. This makes a scientist. Thank you for this. Then, if not, then we would proceed with Sunetra Gupta from Oxford University. And I see that you are a mathematician. not really. Your main area of interest is evolution of diversity in pathogens, with particular reference to the infectious disease agents that are responsible for malaria, influenza, and bacterial meningitis. So you say you use simple mathematical models. To me, they are not at all simple. So, but I accept this is a technical term. Simple mathematical models to generate new hypotheses regarding the process that determine the population structure of these pathogens. And you work closely with laboratory and field scientists. So this is an interaction between disciplines to develop these hypotheses and to test them. So thank you very much for your presentation here.
Well, thank you very much indeed for inviting me. Maybe we should return first to the word simple, because I think there is a tendency, scientists and politicians, with respect to certainly the COVID-19 pandemic, and also to perhaps recent geopolitical events, to say that it's all very complex, and that, you know, the average person has no chance of understanding the basic principles and navigating through it. And that's one of the things I should like to challenge by, first of all, using what are simple mathematical models, simple in the sense that they're fundamental to, you know, that they have qualities that are fundamental to our understanding of the spread, the dynamics of infectious disease. And I think that these fundamental principles are ones that can be appreciated widely by the general public if communicated carefully, and without the sort of shrouding everything that's done in this sort of mystery that, you know, oh, only we, the scientists, can tell the future. I think that was one of the most egregious errors committed during the pandemic. Could I have my presentation? It's not, oh, I see, it's not there already. Okay, so I do use mathematical models to try and understand infectious diseases, and generally the field of mathematical modeling in infectious diseases arises out of the notion that infectious disease is a product of the interaction between two species, the pathogen and what we call, rather generously, the host. So what we've seen particularly explode in the last 50 years or so is this discipline of mathematical modeling of infectious disease, in which fundamentally we think of these as ecological and evolutionary systems, which we can study through mathematical methods that have been available for a long time within the fields of ecology and evolution. So the host is a resource for the pathogen. Sort of fundamental, underpinning all of these models is this idea that the host is a resource for the pathogen. This is a slide I used to introduce that idea to my undergraduates. So if the host is a resource for the pathogen, that immediately leads us to the concept of how herd immunity can arise within a population. So if you think about the host, so in this silly cartoon here, you've got the funny little pathogen, and we've got the host, and the host the pathogen utilizes the host as a resource. So at an individual level, an individual becomes infected, and then they recover, and typically, or not necessarily typically, but often, they develop some level of immunity against the pathogen. Indeed, even while they're simply infected, they are removed from the pool of resources for the pathogen. So the pathogen is eating up its own resources when it spreads through the population. And so what that means is once a pathogen starts to spread, it is basically munching up what's available to it. And so within a population, people become immune, or they're already infected and therefore no longer available for infection. And eventually what this leads to is a situation where the pathogen runs out of resources or can run out of resources. And this can be captured very simply, actually, using a mathematical model. This is probably the simplest mathematical model you can see, you'll ever see of an infectious disease. And in it, what it simply does is it splits the population into those who are susceptible, those who are infected, and those who are recovered. And you write down a set of equations that describes how people move between these compartments. And then you can solve those equations. And when you do that, what you see is how a disease spreads in a population where nothing else happens other than people becoming infected and recovering. And what you see in that graph that I've just shown is if somebody comes in with the infection, an infected person is introduced, the numbers of infections will slowly grow, and then they actually peak at a particular point, and that's because the number of people available for infection has become reduced due to the buildup of what we call herd immunity, or numbers of people immune in the population. And there is a certain threshold beyond which the growth rate of the infectious individuals starts to become negative. And in this very simple situation, eventually people become immune, and the proportion of the population that's immune remains above the herd immunity threshold, because there's nothing in this simple model that changes that. And the pathogen, effectively, you have an epidemic and it dies out. Now, that doesn't actually happen, because what actually happens, people start to lose immunity, even in the case of something like measles, where immunity is lifelong. People who are immune will die, and new individuals will be born who are susceptible. So eventually, the proportion immune falls below herd immunity threshold, and you get a second wave. So that herd immunity threshold is basically a point at which, beyond which, if the population immunity in the population exceeds that threshold, simple rule, the pathogen cannot propagate. If it's below that, it will come back, provided it's hiding around somewhere. And what you really get with most diseases, and essentially exactly what we've seen with SARS-CoV-2, is the whole system tends towards an equilibrium state where the proportion of the population that is immune is maintained at that herd immunity threshold, and there is also a very small fraction, typically, of individuals who are infectious at any given time. So we head towards this, what we call an endemic equilibrium, and not surprisingly, that's exactly what we've seen in the last 4 years. Now, what this very simple model suggests is that if you can reach that endemic equilibrium, the quicker you reach that equilibrium, the better off you are. And indeed, if you can exceed the proportion of people who are immune to being above the herd immunity threshold, you could, in theory, eradicate the disease, which unfortunately we've only been able to ever do for smallpox. So what we have then is this conceptual framework in which people become immune, and then the whole thing settles at a point where, and it's a dynamic equilibrium, the proportion immune is maintained around this herd immunity threshold, and that there is always a constant level of people infectious. Now, what we know is that vaccination can take us from being susceptible to being immune, circumventing that state of being infected. And so in theory, you could expect that if we had a vaccine, such as we do with measles, that you could reach this state of herd immunity. Ideally, you would exceed it, with the proportion immune in the population would exceed herd immunity. But you can reach that state through vaccination, in which case you get there without allowing people to become naturally infected and thereby at risk of death from something like measles. So obviously that was the idea with this is what was communicated to people as that's where we're going. That's what we want to do with SARS-CoV-2. So why didn't that work? The reason it didn't work is because immunity against infection for SARS-CoV-2 is transient. That is to say, naturally, when you get infected with SARS-CoV-2, after a while, you will lose your immunity against infection. And this we knew. So the problem is that what you see now is a lot of scientists say, well, we didn't know that then. And this is unacceptable because we live with 4 other endemic coronaviruses. And for all of these coronaviruses, this is true. You're constantly reinfected. Now, what does that mean? Does that mean that we cannot achieve herd immunity to coronavirus? Quite the opposite. In fact, you have exactly the same herd immunity threshold with an infection where you are repeatedly infected as you do with one where you have lifelong immunity. The difference is that you have to keep being infected in order to maintain that level of herd immunity. And an analogy I sometimes use to communicate this is one of a cistern in which the level of the water that it achieves at equilibrium is always the same. But you could have a leaky cistern like SARS-CoV-2 where the water drains away quickly and it comes in also quickly. Or you could have one like measles where the water trickles away slowly and trickles back in slowly. So what does this all mean then? So you have the same herd immunity threshold, that's where you want to get. In one case with measles, you have a low trickle of infection. You only get infected once really in your lifetime, whereas the coronavirus, you keep getting infected over and over again. Does that still not mean that we need a different strategy when it comes to dealing with a disease where immunity against infection is transient? Well, the first thing you might say is, well, if you keep getting repeatedly infected, doesn't that mean that you have more disease? And the answer to that is actually no. Because when you get, I'll just skip this one. When you get infected by coronavirus, oops, this is not really working. Anyway, you become immune for a short period of time, but infection, or indeed vaccination, confers durable. No, it's fine. Confers durable protection against severe disease. I can do it with this anyway. So fundamentally, we'll go back to that. So what we have here is a system in which immunity against infection is transient, but immunity against severe disease is lifelong. And actually, this slide was simply to say, if you overlay upon that the effects of seasonality, which is just to say simply that obviously the virus transmits better at different times of the year, you can actually recover every single pattern that we've seen of coronavirus, the dynamics of coronavirus in pretty much any setting globally can be recovered by combining those principles. Just that immunity to infection is transient, that to disease it's lifelong, and that you have seasonality. There is no need to bring in non-pharmaceutical interventions into the mix in order to explain any of the patterns. So where are we at now? What I've put forward to you is a very, I think, simple framework that explains everything that happened with COVID. But what does that mean in terms of policy? So, as I said, you do get immunity against, what we want is for people not to die. And we should have known from, we had all the other coronaviruses tell us that infection, or indeed possibly vaccination, would confer durable protection against severe disease. What we also knew was that the vulnerability to severe disease was highly stratified by age and by condition, so that certain comorbidities and your age gave you, defined very closely and strongly what your risk was of fatality from COVID. What that meant is, given all of these conditions and the uncertainty surrounding them, that the workable solution that possibly presented, or the workable solution that presents itself under this framework, very simple framework, no complicated mathematical model and huge numerical simulation that's only full of assumptions. I think that's the key point that Professor Ippolito made, is that the assumptions have to be absolutely secure. And the point about a simple mathematical model is that the assumptions in it can be secure. And everything that I've mentioned so far is based in what we already knew. So the workable solution that we proposed in 2020 was one where we allowed immunity to accumulate in the population by sheltering, but protected the vulnerable by reducing their individual risk. And this was because principally it was also completely obvious at that point that we could not afford lockdowns. I mean, again, people say, oh, we didn't know then. And really that's unacceptable. It was absolutely obvious that we couldn't afford lockdowns. Unfortunately, though, this theory got shot down by the scientific community, and this document called the John Snow Memorandum was prepared, which proposed two quite outrageous things. One, that could be there was no naturally acquired immunity to SARS-CoV-2. This is in October 2020. Then they also said, what if immunity doesn't last forever? Which I hope I've just demonstrated is not an issue at all. But then they raised perhaps the more important and more difficult question of how can you possibly shelter the vulnerable? So there is no simple answer to that, but then there are, if you stop thinking of it as a mechanism by which all the vulnerable people are going to be completely protected, you can start to unpick it. And indeed, in the Great Barrington Declaration, which we wrote at the time, we do make some suggestions of how this might be achieved. So if you start thinking of it more as individual risk reduction for those who are at risk, you can come up with some credible ideas or suggestions. And fundamentally, what that also recognizes is that if you don't shelter the vulnerable and instead rely on NPIs, which we didn't know then and still don't know whether they are able to prevent the spread of infection, what you're actually doing is you're doing worse. We can rely on some of these measures to reduce individual risk. We know that if you stay at home, you will reduce your risk. If food is delivered to you, and if you have what I would like to call state-supported individual risk reduction measures in place, those who are vulnerable can reduce their risk. But those very same measures do not necessarily stop or even have any effect on the spread of infection in the community. And this is a critical point that I think was missed by those who were very quick to criticize this idea. And indeed, if you think about whether social distancing can have an effect on individual risk reduction, there are now studies in place that show that. This is one from this is C.U. Chen's work, which is basically taking data from pregnant women in New York, and what it shows is that the seropositivity of pregnant women in New York in May 2020 was considerably lower than that in the general population. And part of that has to be attributed to the fact that pregnant women who were in their third trimester at the time were, for obvious reasons, avoiding infection. So avoidance of infection at an individual level can actually reduce risk. but that those same measures do not apply at a population level. So fundamentally, I think what we did during the COVID pandemic was invert a schedule of certainties and uncertainties, which, you know, Professor Plato mentioned, how do we operate within uncertainties? And what we were least certain about was the effect of NPIs on the transmission dynamics of disease, and indeed the long-term goal of such interventions. Even if you can stop it for, let's say, 2 months, what's the end point there? We did have some uncertainty, of course, regarding the fundamental biological properties of this new virus, but far less so than was broadcast. And to an extent, this uncertainty was weaponized. What we were most certain about was that NPIs would cause extreme and long-term damage to the most vulnerable. And this is, of course, what we will hear about mostly today, the young, the old, and the poor. And so what do you do under these circumstances? You avoid what you're most certain about, which is the harms of these NPIs. And instead, what we did, what we were least certain about, which is to impose them with this idea that they would stop the spread and thereby protect us. Okay, thank you very much.
Thank you.
They should show unity and they should collaborate. We need a herd immunity system that is still needed, I think, no? But in the last months, we have seen that there are no politicians that are humble, because in America, you know, the new to be appointed Minister of Health is against vaccine. Is there any chance that the scientists could do something? Because me as a citizen, I don't see any hope in the fact that the pandemic is well, I don't know, understood, and you know, it's well organized in a way that next time we are much more prepared. Or food for thoughts, I don't know, but what I see, what I read is that the sciences are completely separate between from the politics.
Humility, which was mentioned by Professor Ippolito, is key. I mean, and that was completely lacking. You know, everyone was acting with enormous, and that people continue to act, the scientists certainly, and the politicians, continue to act with extreme arrogance. They continue to display, you know, they continue to insist that there is certainty on the precise points where there is no certainty, and they deny the certainty there is in other areas. So, no, I think we need a complete culture change, but unfortunately, what's being proposed as a cultural change, I don't think at the moment is going to necessarily lead to the right outcomes.
So definitely one step in that direction is to reflect what we did. And now we hear also opinion from Ippolito.
Yeah, I'm convinced that the analysis of risk perception about societal polarization is common also among scientists and among politicians. The recent report of appointment of future director of a U.S. agency are a bad indicator of polarization. We will have a new director for CDC, new director for NIH, a new director for FDA, and the 3 persons that are on the same line that has been dictated by Kennedy. In this analysis is really problematic, but could be also useful. One of the problems in this system of polarization is the high power of pharma company and the limited investment in research by pharma company that have procedures to buy for few dollars new technology and gain a lot of money after the production. This could be a good opportunity, but we need re-establishing the role of scientists. we have pollution of papers and pollution of publication. The most of the publication are not useful. The analysis of the papers reported for the preparedness and the lesson learned is so impressive. And the analysis of impact that has been reported for lesson learned, very few were really useful. I was involved in some of the meetings organized by the EU on the lesson learned on different diseases across my life. Maybe that the best were organized in Ebola, but the experience was exactly the same. Rich people have access to the treatment, the vaccine, and the poor people don't. The risk of polarization is very impressive with WHO. I believe that WHO is waiting since 1992 of a reform, is still waiting, and now will be the starting point for a real reform of WHO. And the other agency involved, at least 3, involved in the problem of food, drugs, and health.
So thank you very much for this explanation. Before we come to the next presentation from Tom Jefferson, I would like to come back to your question of what we made wrong, probably. And one thing definitely was that we overestimated the perceptions of scientific discussions in the population. And one thing which is clearly seen by Sunitra Gupta's presentation was to show that vaccination does prevent from death. So it's really good not to die from corona, but the expectation that this vaccination campaign and the discussion awoke was that we are protected from infection, which is 2 different things. So in my area where I come from Cologne area, we say, well, not to die is also very nice. And it is not the major aim to be not infected. So I just wanted to emphasize this. So now we come to Tom Jefferson, and he's ready. Okay. Tom Jefferson is Senior Associate Tutor at the University of Oxford, so a colleague of yours from the same university, a former researcher at Nordic Cochrane Institute Center, and a former scientific coordinator for the production of HTA reports and non-pharmaceuticals for AGENAS, the Italian National Agency for Regional Health Care. So, physical interventions by Tom Jefferson.
Okay, so that's what I'm going to talk about. And this is a Cochrane review, and it's the story of the Cochrane review, and it's the content of the Cochrane review. Can you put the next one on, please? That's the full reference. No. One back, please. That's the full reference to the review. I am the first author because we have activated the grandfather clause. I am the longest serving on this review, but I have no other title to be first. Okay, so this version was published in 2023 on January the 30th. Now, this is important, this date. Okay, one down, please. Now, this is the history of the review, and you will see down at the very bottom that the protocol of the review was published in October 2006. A year later, we published the first version of the review, and then we have 4 updates since then. So the review has been long-standing, and you can see this history if you access the review. Any details which are missing in this presentation, you can find on our Substack, Trust the Evidence, which you see the logo of on the right-hand side. Okay, could you go to the next one, please? So this is the Google Scholar tracking of the review, and it starts in 2010. And as you can see, nobody really gave a damn about what we had to say about physical interventions. We never used the word NPIs. I personally don't particularly like it, because the word NPIs tells you what they're not. It doesn't tell you what they are. They're basically physical interventions of different kinds. Now, as you can see, no one really was interested. The review itself was republished in the BMJ twice, as well as being on the Cochrane Library the whole time. And this was until 2020. And then you can see what happened. In 2020 alone, we had 434 citations. Next one, please. And we had this boom in public PubMed accesses, you see. So no one really took much notice until the COVID pandemic struck. Next one, please. And believe it or not, it's now number 9 out of 25.5 million items on Altmetric. And this is the Altmetric score. For those of you who are not familiar with Altmetric, it's a general measure, multi-source measure of interest is a review in the review. It's up on the 99th percentile. So you think I'm really chuffed about that, but I don't really. It doesn't really fuss. It doesn't really make me smile or make me sad. It's just people's interest in the review, which is not really surprising given the context in which we have been in for the last 4 years. Next slide, please. So what are the results of this monstrous piece of work? Because it is monstrous. We read hundreds of studies. The latest version has 78 individual randomized or cluster randomized trials. And the vast majority of these were conducted during periods of ILI, influenza-like illness circulation. And a few were done during the 2009 H1N1 influenza pandemic. 6 of these were done in the SARS-CoV-2 pandemic, and 4 at the time that we published the 2023, the January 23 update. 4 trials were ongoing or unpublished at the time, but we did manage to include one of them in our just as it was still unpublished, but we knew what the results were and the data. Now, one point that some observers miss because they don't read properly is that we had observational studies. They were included in the review from 2020 onwards. And, up to 2020. And from 2020 onwards, we dropped because we had a huge, I beg your pardon, this is my dog. She's probably barking at the Martians. I hope this is not causing too much. Stella zitta. Okay, so the observational studies were not included and not updated from 2020 version. So we dropped them from the 2011 version. Next slide, please. When we did the first comparison, this is medical and surgical masks compared to no masks. We had 12 trials, and which 10 were in the community, and 2 trials in healthcare workers. The outcomes were both generic, ILI, and influenza and SARS-CoV-2 outcomes. As you can see, the numbers are very, very, very large, but there's a lack of effect in overall in the meta-analysis that we carried out. Now, the last point is a recurring point in the history of the review. The harms of these physical interventions were rarely measured. And when they were measured, they were poorly reported. So we called it very low certainty evidence using grade. Next slide, please. In the next comparison, we looked at slightly more difficult to wear and more complex devices, N95 respirators compared to surgical masks. And again, the story was the same, very much the same, both for generic outcomes like clinical respiratory illness, ILI, or more specific outcomes, which like influenza. Again, the harms were a problem in the sense that they were underreported, underinvestigated. One ongoing RCT was published, as I said, after the publication of our review, and it was a non-inferiority RCT looking at N95 versus surgical masks in healthcare workers in several countries. And again, they found no difference against SARS-CoV-2. Next slide, please. Here we got a little bit of good news because hand hygiene compared to control, we had 19 trials. We had quite a number of participants in these trials. And the interesting thing was that when the outcome was a generic ILI, there was a 14% reduction in infection, or at least in cases. But when we looked at the ones that actually reported influenza, positively identified influenza, that effect seemed to disappear. But there was only 8,332 participants in that one. So we pulled 19 trials and we did a composite outcome of ARI or ILI with influenza. And again, there was a 11% relative reduction in respiratory illness. And you can see the data there, and you can read it at your heart's content in the review itself, which is open access. Again, we had few trials which measured and reported harms. Next slide, please. This is a miscellaneous various interventions looking at variety of mixtures of hand hygiene, hand sanitation. You had antiseptics, gargling, virucidal tissues. You had people with washing their hands with ash, with and without soap, and so on and so forth. And the effect of hand washing seemed to be small, but present if compared to no hand washing or routine. The interesting thing is that the first, if I remember right, the very first trial in the series dated back to 1981. Next slide, please. So we couldn't find any RCTs on gloves, shields, screening, identity reports, but we did find one on glasses. The evidence base is very large, 610,000, but the uncertainty persists because it is technically very, very difficult to carry out some of these trials. And compliance in some of them where was not high, and they were carried out in a variety of settings and a variety of populations, from Bangladesh to North American student accommodation. So it's very, very heterogeneous evidence base, as you would expect, because that's what the universal nature of these physical interventions is, exactly what you would expect. Okay, next slide, please. I want us to focus on two interesting studies that nobody ever mentions. The first one is by Ipfelt and colleagues. It was published in 2015, and it was carried out during the winter of 2014-2015 in Copenhagen. It was a cluster randomized trial in 12 nurseries. 6 were in the intervention cluster, and 6 were in the control cluster. Total was 587 children aged 6 months to 3 years. What they did was, first of all, they swabbed all the surfaces of the 12 nurseries, and then they instituted in the 6 intervention nurseries, they instituted a regime of surface cleaning and disinfecting every 2 weeks for 3 months. The control nursery carried out as normal. So it was basically cleanliness and disinfection versus do nothing. They then followed up and looked at the absenteeism through ILI. What they found at the beginning, to begin with, was that every single surface was loaded with just about any pathogen you can think of. And here I've listed the main viral pathogens that were identified. So OC43, Boca, adeno, RSV, rhino, I think there's metapneumonia would have been, and so on. They were there on these everywhere, and both sets of surgeries. Sets of children homes, daycare nurseries, sorry. But the intervention had no effect on ILI sickness rates. In fact, it's completely the contrary. After the trial had finished, in the two out of the 6 intervention nurseries, they had an outbreak of ILI, whereas in the control nurseries, they had no such thing. Interesting, isn't it? And a bit counterintuitive. The PCR testing, which they'd done, was poorly reported. So we have no idea whether these agents that have been identified were actually replication competent or not. But antigens of these agents were everywhere. Next one. This one is a trial from the 2001 H1N1 influenza pandemic. This is Miyake, and it took place in Japan in a car factory. It's defined as a cluster RCT, maybe not. This is about enrolling 15,000 workers in a car factory during the pandemic and saying to them, look, if you've got people at home who've got symptoms of ILI, you can stay at home. We'll look after you, we'll pay you, and you can come back when you are fitter, when you're feeling better. And we'd like to know then what happens. Basically, this is an isolation trial. Well, what happened was that the rate of ILI went right down, and people in the factory and people kept on making cars, whereas it went right up in the family, and a lot of these workers were infected by influenza H1N1. So this is right in the paradigm of germ theory. This fits with the paradigm of germ theory. Next one, please. This is my last but one. There's a vast evidence base, so high uncertainty in the mix of interventions, poor reporting, but there was no political will to fill the gaps. There could have been, and there still is, lots of time to test some of these some of these physical interventions correctly, well, with large numbers, against all sorts of pathogens which are currently circulating, including SARS-CoV-2. But there doesn't appear to be any political will, or very low political will, to fill the evidence gaps. Next one, please. That's a shame, because the history of challenge studies and studying respiratory viral transmission goes back a very long time. It started in 1918-19 on the aftermath of the influenza, so-called Spanish influenza pandemic, and it was carried out in the 30s, 40s, 50s, 60s in establishments such as the one that you see, the MRC Common Cold Unit. which was opened in 1946 and had some remarkable achievements, such as the isolation and recognition of the first rhinovirus, the isolation and recognition of the first coronavirus, and a whole string of experiments, 1,006 experiments carried out in 19,000 plus volunteers over the time of 1946, 1989. And it was closed in 1989 because we had conquered respiratory viruses. So with that, I will thank you and leave you. And if you've got any questions, I'll do my best to answer them. Thank you.
So thank you very much for this presentation, and greetings to your dog. I hope he survived it.
No, she's in a coma.
Okay.
She's heard it so much time, so many times that she's in a coma.
So I have one question that I already discussed with Sidnetra here, but if there are now already questions in the audience, then we can take this first. Otherwise, I would like to share this thought with Sidnetra, what we had. It was about the study in Copenhagen. Can we expect from the numbers a difference with respect to the disease? Maybe there might be an effect in difference to infection rates and not to symptoms. So because the numbers are quite small. So this is what we discussed here.
You're talking about Ipfeld?
Yes.
Yes, that's possible. My main problem with Ipfeld is that the PCR results were not clear. And this is a fault line which runs across the last 4 years, but even before that. The problem is the majority of people don't understand how PCR works. They don't understand its great strengths, and they don't understand its limitations, and they don't understand how to report it. So as I said to you, I have no idea whether, and I don't think the authors have either, unless they've got frozen specimens, we have no idea if those agents that were found on the surfaces were actually replication competent, or they were just simply antigens that the very sensitive PCR probes identified.
Thank you very much. Any comment from Sidnetra?
I just wondered, well, two things. When you conduct or analyze these studies, are you looking specifically for measures that will effectively translate into individual risk reduction in particular settings? Or are you thinking more broadly about testing them for whether they might limit the spread of a disease under particular circumstances?
I think it's the latter, but I have to preface that, Sidnetra, by saying that the reporting of some of them, apart from the fact that some of them are very ancient, as I said, very old, the reporting of some of these is very limited. And there's a lot of attrition, as you can imagine, especially in the mask studies. In the hand washing studies, it's very interesting because there was a clear effect when teachers followed the hand washing periods of the children, for instance, in schools. As soon as that was, you had a rebound effect. So this would seem to suggest that these measures, if they have an effect, they are a short-lived effect during perhaps periods of higher viral circulation.
I suppose I'm asking that because I think if they work at all, they would perhaps be useful for delivering focused protection rather than trying to stop the thing from spreading altogether.
And indeed, that's what we should be trialing now. This is precisely one of the questions which we should be trying to answer, and we should be trying to diminish the uncertainty around questions like that. Answers to questions.
Ok, Vittorio Colizza, INSERM, Institut National de la Santé et de la Recherche Médicale, if I remember well, SARS-CoV-2 transmission in school and policy decisions. I can.
Thank you, Andrea. I'll actually stand if I prefer. I gave too many talks during the pandemic in front of a screen, so I really like to stand. Andrea, can I ask you to give me a sign at -5 when in order so that I can pick up my pace if needed? Thank you. So first of all, let me thank Francesca Incardona and the EuCARE consortium for this invitation. For me, it's as soon as she sent me the email, I thought, well, that's a great opportunity to exchange and maybe debate a little bit. There's probably going to be a little bit of discussion about the results on schools. And what I will present, and I think Afira will need a remote over here. Thank you. No problem. What I will present today is the situation in France, and especially what we did in terms of school transmission and advice for policy decisions. So just to have a look at the context of what happened in France. You see, of course, well, the dynamics of the pandemic was very similar to what happened in Italy and very many other European countries. First, second, third wave with Alpha. You can see the vertical blocks which identify lockdowns of different stringency that were put in place in order to face the different waves. Schools were only closed during the first lockdown. As soon as the lockdown was lifted, then schools were reopened, and they were always open in presence. Little exception during the third wave, the Alpha wave in the spring of 2021, where schools were actually on scheduled holiday because it was what they're generally called the spring and Easter holiday, and they were just extended of 1 week. But if we'll go back and look at what happened in Europe, this is something that Francesca mentioned at the beginning, at the opening. So these are the data that we collected from UNESCO on the number of weeks of school closure, that could be partial or total, depending on school degree and level, in European countries from March 2020 to October 2021. And you can see that, of course, there is a wide range from about 10 weeks of school lost up to almost a full year, about 50, but it's much more, of course, than a school calendar year. So France is over there, is just second country in Europe with the smallest number of weeks of school closure. Europe, of course, is there in the middle. Italy, just as a reference frame, is over there. So clearly, this is associated to different policy decisions. But at the same time, to me, it was rather clear since the beginning that this was also related to a large level of uncertainty, limited knowledge of what we knew and how then we improved our knowledge over time for what concerns transmission in children. And especially whenever you have a very limited knowledge, well, distortions on this knowledge and nuances and interpretation, if not to really misinformation, can truly happen. So going back to what, for example, Giuseppe was presenting before, one of the very first statements that came out was, and here again, I'm referring to a French context, was that children were not affected by SARS-CoV-2. This was related to a set of events and circumstances. So first of all, we didn't know about the susceptibility of children. Then children were doing, most of the cases, symptomatic infection, so not visible because we were not testing at the time. And also at the very beginning, some of the waves happened during school holidays that were already scheduled, like in China. Or instead were concurrent with school closure, which were immediately closed in many European countries as soon as the situation started to be concerning because of pandemic influenza preparedness plans. But an early study, here of course citations relate to the publication, but meta-archives were already available. An early study on a cluster of cases in a school in France in February 2020 already showed that there were circulation in the school from serological data and investigation showed clearly that children were infected, and also pointed out first preliminary evidence that maybe adolescents were probably more prone to infection than children. So it's true that you have a very limited knowledge, but still mathematical models can also help when you have a large set of uncertainties, especially when you have thresholds. For example, when the first lockdown was lifted in France, the government decided to reopen school, which was quite unusual, especially compared to the decisions of other European countries, was quite unexpected also for parents of children who were afraid of sending kids back to school in a situation that we didn't know exactly what it was like. And so in that moment, there was a lot of discussion about how to best plan this reopening. So in a situation in which you have, large uncertainty, but at the same time, you have also threshold effects, like, for example, will hospitals saturate or not? So mathematical models can explore very different situations, very different scenarios, explores also parameters that we don't know, and let us know whether some of these scenarios would be below, for example, hospital saturation level, or maybe above this level. So with that, we provided some information suggesting, for example, to reopen schools progressively, not all of school levels at the same time, but delaying, for example, high school reopening. And then also we did a ex post assessment showing that clearly after we collected a lot of additional data on presence at school, also on adoption of preventive measures, etc., we showed clearly that there was the progressive reopening of the school, the limited attendance also, because that was a voluntary physical attendance at that point, and the strong adoption of preventive measures that led to the curve that we saw. Then other statements, of course, as knowledge evolved over time, other statements were emerged. So after the first one was that children were, yes, they could get infected, but they did not transmit the infection, which for somebody working in infectious disease, it's quite extraordinary in understanding, especially for respiratory infections. Children could get infected and transmit, but that was not happening at school. Which again, thinking about the fact that anyway, they spend about 8 hours or slightly less in the schools and then 8 hours they sleep. So at least one would imagine a contribution that is non-negligible. And then the final one, which is the killing statement. These are only modeling results. We're not sure that with Giuseppe, we can discuss about this statement a long time. So what we did was, quite early on, it was clear to a lot of let's say the extent of the scientific communities, that closing schools had a lot of impact on children in terms of development, in terms of interaction, but also an economic, of course, aspect for parents to be allowed to go back to work. And so starting this summer 2020, we started to develop models that could help the decision of the authorities in keeping schools open, but to safely keep them open. Because every time you have an infection that goes unseen, because most of the times it's asymptomatic, that could be a perfect excuse to keep things open and do nothing. So what we wanted to do was, first of all, was to estimate transmission in school setting. We wanted to understand then how to reduce that transmission. And while doing that, we wanted also to minimize closure. Otherwise, we were back to 2.0, and at the same time, trying to optimize resources, because, of course, every intervention has its own cost. So we started with the use of RFID tags. So we started really as a basic element, trying to understand better how contacts between individuals at school occur. Generally, we use in models some homogeneous mixing model. What we used was RFID tags. So these are tags that are used like a conference badge. They are radio frequency, and they can talk to each other whenever two tags are face-to-face. Also to note that they don't, so they really look at interaction that is face-to-face, about 1 meter, 1.5 meters distance, with an opening angle of about 120 degrees. And they, for example, they would not track if I was, for example, giving the back to the person, simply because our body is made mostly of water, so absorbs these radio frequency signal. These tags have been used in the past in many, many different circumstances. And of course, in school, for example, there you can see a map of the contacts occurring in a primary school in France, where each dot corresponds to a student. The classes are organized in this circle. The dot at the center is the teacher. And you see all these different links which correspond to the measured context. The thickness is coding the length, the overall duration throughout the day of the contact. Immediately you can see that this is far from being homogeneous, but also if you look at the context, you can see that clearly there are differences of contacts within class, between classes, among students, with the teacher. And also there is a large difference between contacts, for example, in primary schools that are only counted in terms of number of contacts, and instead whether we count the duration of these contacts. And if we're talking about disease transmission, of course, we want to be quantitative, more precise, more accurate in terms of duration of these contacts. Then we coupled these data with, of course, an infection transmission model that was age-specific features that, of course, was adapted over time to integrate variants, testing of different types, delays, etc. And the biggest, the biggest challenge there was actually to access then testing data, because, as I said, we were not testing in schools, we were rarely testing kids. But it happened at a certain point. This was the alpha wave, so we're talking about spring 2021, where in the region of Lyon, there was a pilot testing that was offered around the Easter holidays in different schools. Now, these were not perfect data, clearly, and was far from being so. But still, we were able to access about 800 screenings in about 700 schools. So most of the screenings were performed only once. This was giving us a cross-sectional view of the infection status in the schools. About 200 students testing and 200,000 and about 20,000 personnel tested. Now, based on that, we fitted our model to this data, and we were able to have our first evidence on transmission in schools, and also then how to improve protocols. So the first evidence was that transmission in schools, yes, was happening. And also that was more or less of the same contribution of transmission that was happening elsewhere. So transmission in the community from families, from interaction activities that occur outside the school. And then based on that, we wanted to provide some information on how to best improve our protocols in order to reduce the number of cases in kids, because this was generally related to some closure of some type. So we compared very different protocols over here. And you can see, for example, that reactive class closure was not bad. It was providing about 20% of reduction in the number of cases, estimated to provide 20% of reduction in number of cases. Reactive screening, which was then largely introduced in France, starting the second calendar year, was instead performing worse, about 10% reduction. And the best was a systematic testing that, if adherence and frequency was increasing, would provide a quite high value of prevention. For example, if individuals, so students, were tested, 3/4 of the students in a school were testing once per week, we estimated about 50% reduction compared to symptom-based testing and isolation alone, which was quite good. At the same time, of course, these were only modeling results. So we were told that. So what we did was, and of course we were criticized for that, but at the same time, that led to a new collaboration with the Ministry of Education and the Ministry of Health to define and design a protocol for weekly screening in schools. This was then introduced again in the region of Lyon. So here you have different departments of Rhône, Savoie. And it occurred during the Delta and then the Omicron waves. So this was the Delta wave before December 2021, and then the Omicron wave at the start of January. So those were the prevalence at schools that were measured with this weekly testing. And again, we fitted our model to the data that you can see over there. And so we provided the estimation on the value of these measures. So we showed that the contribution of transmission occurring to school to the overall number of transmissions for kids was between 50 and almost 70%. So reconfirming what we had from worse and more limited data in the spring of 2021. And then we could compare the performance of this weekly screening, which was happening only in the schools of this region, in some of the departments of this region, compared with the reactive screening that instead was happening in the rest of the other schools. And by doing that, what we showed was that
Victoria,
during Delta,
5 minutes, please.
thank you, during Delta and Omicron, the prevention, the estimated percentage of cases that were prevented thanks to the application of the weekly screening was about 40%. So we were, and the adherence was between 70 and 80%. So we were not bad with our initial predictions, which were giving, the very first ones were giving at the start of 2021, towards the end of 2020 and the start of 2021, the only modeling results, and were given to the task force of the Ministry of Health and the President. To note one element is that this was a pilot experimentation in those departments, and it was meant to happen exclusively in the month of December 2021. Then when Omicron happened, some of those schools asked the minister to keep staying on that protocol. The buy-in cost was very high, organization, logistics, etc. But once it was rolling, it was much easier for parents, school directors, and also for the labs to have that type of screening than instead, you will see in my next slide, recurring to an enhanced and strengthened reactive screening. So what happened instead, that France, didn't want to follow up on that screening, even though it was shown to be successful. The reason that they used was that it was impossible to do that. It would have been impossible to do that for the entire country because of too many tests, so too many resources. So I started wondering, when Omicron arrived, the incidence was so high. At that time, France decided to opt for strength reactive screening, meaning that after the detection of a case, all the other students in the class had to test 3 times in the time of 1 week, which is a lot when you have that high incidence. Switzerland was using weekly screening with pretty high adherence. Italy was under reactive class closure. So we tested the protocols of the different countries. And what we saw indeed was that at the time of the Omicron peak, the incidence was so high that the demand of testing, even when using a reactive screening, so only when you find a case, was of the same type or even larger than what was requested by weekly testing. Now, this was due to two circumstances. On one side, the weekly testing was preventing some of the cases, and so was more efficient in reducing the incidence. At the same time, of course, then this number was reduced right after the peak, also because of the absence at school. At the same time, instead, reactive screening with 3 tests per each student of a class after detecting 1 case was exploding at the time of the incidence peak. And indeed, photos started to circulating in the media that while in the rest of European countries, kids were in line for vaccination, instead, in France, they were in line to get tested. But then we went a little bit further, and we wanted to see at varying incidence levels, what was the performance of these protocols, not only comparing the reduction of the peak, so a reduction of number of cases, but also looking, for example, at the student days lost. So here we looked at resources, and this we looked at the impact for the students in terms of student days lost. What we found was that reactive testing, was not that efficient. We saw that before, but at the same time was not so impactful on the school. The interpretation was that, yes, because it's not efficient in finding cases once you do this type of approach. If we looked at weekly testing, that, for example, was the protocol adopted in Switzerland, there was a range of a peak reduction between, for example, ranging from 10 to 50 and more %, depending on conditions of adherence and then also frequency. And the amount of student days lost was limited, not going higher than 15%. Well, instead, if we looked, for example, at reactive class closure, in terms of peak reduction, this was quite important, estimated to be about 20%, as we saw before. But of course, the downside was that classes were repeatedly closed, even in circumstances where testing could have avoided the absence of individuals. So leading to about 25-30% student days lost, which is compatible with what was reported, for example, in Italy during the Omicron wave in terms of schools closed at that time. Now, from pilot to the actual protocol, Switzerland then, throughout 2021, decided to adopt a weekly screening through a pooled strategy, and I think this is maybe quite similar to what was done within EuCARE project. And so we started analyzing this full data throughout 2021, and our preliminary results, which are now trying to consolidate, is that again, we found that transmission was quite high also in the schools. So about 50 to 60%. These estimates were then aligned with similar estimates of school transmission conducted in Belgium and in some Italian schools in the north of Italy conducted by Fondazione Bruno Kessler. And the percentage of averted cases compared to reactive class closure, which was instead the protocol that was in place in the rest of the cantons of Switzerland, is about 30 to 40%. So we go back to some of those percentages, which were our early findings of our poorly modeling results. So let me conclude, and let me, of course, thank also my funders that supported this work, but specifically then Elisabetta Colosi, who was the real engine of a lot of these works on transmission in schools. Thank you very much.
So, first of all, let me say that the first report that was really shocking all of us was from France, when you discovered or reported from if I translated it correctly, a boarding school, internat is what we call it in Germany, so that the teachers and students stay all day together and all night in the same building as a boarding school, right? And there was a report that after 4 weeks, they found out they had a disease running around, and 50% of the people in this building were infected with SARS. So that was those news that were really shocking us and that were driving us to introduce such measures also in Germany and testing. So my question is now, did I understand you correctly that during Omicron, that was a 15% loss of lectures when screening versus 25% loss of lectures when no screening? Is this summary correct?
It depends on what type of screening, because we tested 2 different types of screening. One was reacting, so you would test the students of the class only if you find a case. And that case can be found either because he has symptoms or because there are cases for example, at home. So they test everybody in the family. And the other one was instead systematic screening. So your question was again?
So understood from your data that testing was leading to less loss of lectures.
Yes. Yes, absolutely. Because even if you find, and this is the counterintuitive, let's say, result, even if you find more cases, because you're able to identify them and prevent them, by putting them away because they are isolating them, you break some of the chains of transmission. And so that means that you have less infection that you're going to find, and so less student days lost overall at the end of a wave.
Because you do not send them all in quarantine. That would be the other exactly. Not everybody, only the ones who are positive. Yes. Yes. Okay. Which, when you have a reactive class closure, means the entire class is at home. So again, from my side, thank you very much, and there.